this newly formed society that is still in its infancy, in a structured way. But the roots of this society goes far back. Maybe some of the seniors here can correct me, but I believe the early ideas of forming this society started in 1991. And then I think 92 or 93 was the first meeting of this society that happened in collaboration with the Pakistani neurologist within Pakistan. So Pakistan Society of Neurology was formed in Pakistan, and Pakistan International Neuroscience Society, or PINS, was formed here in North America. This has been a long-standing collaboration since then, with many leaders from Pakistani neurology and neurosciences who continued the tradition of annual meetings through updates, presentations, and discussions. And then gradually, as they got busier and busier, this continuity got broken for a few years. We are now planning to restart that tradition and inform the gathering and group of all the neurologists, neuroscientists from Pakistan and North America. We are now doing it in a more organized and structured way. We have registered this organization and getting a 501c status for it. We have started a few years ago with an effort of bringing everyone to a platform. We started a WhatsApp group for the neurologists and neuroscientists in North America, and we have more than 200 members in that group right now. And then we recently formed an executive committee through the first elections, with an idea to see if this elected executive body can give it a formal structure and organized structure. So I'm part of that executive committee along with my colleague here, Dr. Junaid Kalia, who will be moderating the session today. And in addition to organizing us, there are a few things that we really are looking forward to doing. For the neurologists and neuroscientists in North America. I'm from Pakistan, and one of our key idea is to promote mentoring, help young faculty, junior faculty, residents in training, and other physicians from Pakistani origin get the guidance that they need, get the breadth of scope of things that are possible, realm of possibilities, to be able to become the leaders in their field. Let me recognize other members of the executive committee who I see in the group here. I see Muhammad Taimur Khan, who is actually the force behind putting this together. I see Dr. Adil Memon, and then I see Dr. Tariq Alam here from the executive committee. So this will be first of our series of grand rounds, where we'll invite top leaders and entrepreneurs, especially if they are of Pakistani origin, but anyone who can help guide us as a group and our juniors to promote their careers, to do better, to be a leader from various different backgrounds and aspects. And I am pleased that Junaid and Taimur decided to kickstart this process with a true entrepreneur and a career that is not typically many of us think about when we are thinking mostly of clinical careers. And I think that's really important to see all the different aspects of possibilities. So I'm really pleased for Junaid, and thankful for Junaid and Taimur for doing this. So Junaid, back to you. Thank you.
Hello, everyone. Thank you so much for joining us. I really appreciate what Don has said. And then the key issue over here is to increase the spotlight on our innovators and then provide their guidance to our juniors. So that's the whole idea behind just not your regular run-of-the-mill grand rounds in producing just evidence-based research, but to get into the nitty-gritty of it, that how to improve entrepreneurship, innovation, etc. So this is fantastic because Dr. Khan Siddiqui is one of the innovators, and he's the perfect example for achieving that excellence beyond clinical expertise. And I'm very grateful that he's on our inaugural session today. Dr. Siddiqui is known for what you can see on his background for hyperfine, but even before that, he has a significant long history in health information, health technology. He has founded few companies, and he was at Microsoft and has a very significant expertise in image analysis, deep learning, and artificial intelligence. So I'm very grateful, Dr. Khan, that you are here. Before we start, I wanted to make sure that we have some house rules. Please make sure that you're muting yourself. We'll be taking questions. And then if you don't mind putting in the chat, and if there's something that requires more than just chat, I will probably unmute you, and then you can definitely ask your question at the end. The way the agenda is set up today is that we will explore the entrepreneur, his journey, his life, what led to him to be this amazing scientist plus entrepreneur. And then we're going to get into the key discovery that he has produced. So this way we get both the knowledge of the process and the end product. Before I get into that, again, Dr. Siddiqui, thank you so much. And I will give it to you to properly, again, reintroduce yourself, because I'm pretty sure I missed a few things, and then take it from here.
Thank you, Junaid, and thank you, Danish. Great to be here. I'm humbled that you guys invited me in your inaugural session, so I don't think I deserve it, but let's, what I'll do is I'll walk through quickly in my journey through a few slides, just go show one example on how we will get to, one example of how innovation drives, right? It's hardly ever one person, it's always a team that makes it happen. And it's always what I call, it's never rarely a eureka moment. It's always small nudges over time that happen across different people that actually lead to innovation that happen. So let me share my screen and I'll walk you guys through some of the journey. So my journey started in Hyderabad in Pakistan, where I think I was 11 years old in 6th grade, where I got exposed to a PD-11. PD-11 is one of the old school computers that was installed at the Atomic Energy Medical Center in Jamshoro for nuclear medicine gamma camera applications. But as typical, this is what, late 70s, early 80s, that the interface that connected the camera to the computer never came. So there was a computer sitting at Atomic Energy not being used for the clinical application. So my first exposure to computer was in the context of healthcare. I learned how to code on that computer because just sit there, do nothing as part of my, that's another long story why even I was there, and learn how to do, obviously the first program I wrote was the game Hangman on this PD-11 computer. And the journey kind of went from there. That kind of gave me exposure to technology, integral part of healthcare. And can you imagine, this is Jamshoro, Pakistan, where I'm getting exposed to technology in healthcare for the first time in 6th grade as an 11-year-old. So I always seen healthcare as very technology focused. I ended up going to Aachen for my med school. And again, same thing. By this time, I had already built software for enterprise. I had a software company that was doing exam management system that I acquired just before I went to Aachen. And Aachen, I got sucked into literally my second week there into some kind of data analytics projects from faculty, because can you imagine 1990, a med student who knows how to code was a pretty rare occasion in Pakistan, right? So much so that when I left, my final year thesis was on data mining. So did one of the first mainframe data mining projects in Aachen to show that you can actually do total quality improvement projects on financial outcomes and nosocomial infections purely using data from mainframe. And these mainframe used to be an old Meditech system that required punch cards to program this. So it was that kind of that old stuff. And then the database that Meditech system used was called MUMPS. It was built at MGH by two informatics physicians. I didn't know who they were. So, but as learning the database and how to do this stuff, I would email them because their contact information was available in the manual, and they would respond back to me. And what I'd learned later on, that these were the gods of informatics in the US. So it was Octo Barnett and Bob Greenis. Bob Greenis ended up being chair of biomedical imaging at Harvard University, and Octo was head of informatics at Columbia. I didn't know who they were. I was emailing support people and asking them questions, and they never responded as if they were some big shot. So, and again, this is pre-internet days, so I couldn't even Google and find who they were, right? So that was my exposure, understanding databases and EMR, again, all in Pakistan. I did my medicine training at my internship at NYU. And again, because of my exposure to mumps, when I was at the VA as one of my rotations, they were implementing the new CPRS EMR over there. And my first rotation at the VA was in the ICU. And my first weekend, I had 12 patients in the ICU to take care of, and I went home post-call at 5 p.m. on a weekend, and I made a decision that that's not happening again. I need to figure out how to optimize my process. So I wrote a template-based reporting application to expedite my progress notes. And immediately, next thing I know, my internship got converted into electives in IT. And I worked with the VA IT department at Heinz VA here in Chicago to build what is now the template-based progress note and CPRS. So again, very earlier on, I got sucked into EMR. And again, because VA CPR is also based on MOMS database, gave me a lot of advantage to understand how the database worked. I did my radiology residency at Geisinger, and same thing as a first-year resident, I was asked to help find the PACS. So chaired the PACS selection committee at Geisinger as a first-year radiology resident, selected a beta PACS out of UPMC, built by Paul Chang, called Stentor. And we were the first site outside UPMC that implemented that PACS and did really well. And after that, they wanted to go to electronic health record. And again, the CIO asked me to be on the EMR selection committee. We ended up investing in a small startup out of Madison, Wisconsin, because nobody could satisfy our RFP. Remember, Geisinger was a HMO, so a lot focused on quality-based care, not fee-for-service models. And a lot of the RFP requirements of use cases were all quality initiatives that at that time no EMR was addressing because they were all built as billing systems. So the startup that we invested in at that time was called Epic. And the rest, how that happened, right? And again, Epic was also based on MOMS database, so it gave me a huge advantage, really understanding how the system is integrated, and a lot of work with the engineering team to make that work. I then decided, by this time, I was doing, my focus was on cardiac MR as my main clinical specialty. Again, I was focusing mostly on pediatric cardiac MR at that time, and I thought that's what I'm going to do as my clinical career. But then I think my wife convinced me, like there are only 7 people in the world who care about your cardiac MR research. But this IT committee meeting you go to and everybody sings your song, so why are you resisting career in that? Because as you see from a journey, right, I never thought in informatics as my career in the early days. So I finally gave in, and I thought that there needs to be some kind of training program in informatics. I also had what we call now the imposter syndrome, that didn't think I've gone through, undergrad education or college education on computer science, so I probably don't know anything. So convinced the chair at University of Maryland to start the first imaging informatics training program. And he said, I'll start it if you come and run it. So instead of doing a fellowship, I ended up starting a fellowship at University of Maryland in combination with the Baltimore VA. The claim to fame in Baltimore VA is that that was the world's first filmless hospital. That when it opened the doors in 1992, it did not have a film library. As I said, can create country's first informatics training program. A lot of tech transfer happened out of that. A lot of startups came out of it. One of them that I led was initially called Yada Look. It was a natural language processing based startup that then renamed as Montage and then sold to Nuance Communication. Then got recruited by Hopkins to build the Center for Biomedical Imaging Informatics and Center for Technology Innovation, as well as the Software Tech Transfer Office at Johns Hopkins. So did that with more than 40 million in annual tech transfer that happened at Hopkins. And at this time, we did some very interesting work in AI, and I got recruited then by Microsoft to come and start the medical imaging efforts as well as the machine learning AI efforts in 2007-8 timeframe. And I'll come back and show what we did at Microsoft. I left Microsoft in 2012 to start my next company called Higi. It's a medical kiosk that you see in grocery stores and pharmacies in North America. Scaled that company to about 11,000 of these devices deployed in retail pharmacies and health systems with over 70 million patients on the PHR, and exited that in 2018. Then a bunch of my former colleagues from Microsoft decided to start a data AI company. So I'm chairman of that company and got on a bunch of boards and started doing some investing. And then in 2019, I got approached by Dr. Jonathan Rothberg, who was starting this crazy idea of getting an MRI scanner to the patient's bedside, and joined Hyperfine as the chief medical officer and chief strategy officer to help get the device through regulatory process and commercialize it. So as you can see, I've done a lot of different things. So what I'll do is I'll walk you through just one aspect of it, how things evolve, right? So I've always had this thought process that, GPS has changed how we look at data, right? Just imagine if you had Excel spreadsheets every morning with road traffic data, with each street and the speed, and you had to figure out what route to take to work. You would have no idea. You would not be able to do this. But guess what? In healthcare, what do we do in healthcare? That's what we do, right? We get spreadsheets of data with lab values and medications, all the stuff, and now we have to compute in our head what is happening in the patient. And we have this vision that if you can represent the data in a more of a GPS manner on a human body, aka medical images, you can probably have a better understanding of and correlation understanding of what is happening in the body. So we started this work on machine learning in 2003 to automate classify CT scans based on anatomic regions, so you can represent data based on that. I won't go into details. It's the whole story how this even happened and started, because GPUs to do machine learning didn't exist in this time. So we were creating our custom proprietary FPGA cards to do this work. And that led to a lot of different works, right? Automated classification of images and anatomic regions, automated hanging protocols, and processing based on, now that you know what organ is in the image, you can change window levels automatically. You can create 3D post-processing applications to run automatically. You can create hanging protocols that happen automatically based on what you're looking at. And then we went even further, like, can we classify disease directly? So this was work to classify a meniscal injury and on knee MRs with high probability. As you can see, here's just one of the prototypes that we had done using machine learning to classify images and be able to represent that in an appropriate manner. So these are early deep perceptron networks. This is before neural networks were the hype, right? This was all based on SVM, regression forests, and deep perceptron networks. Those are the early versions of networks that existed at that time. So when I got into Microsoft, one of the projects we had was to how do you create photorealistic 3D imaging, right? This is used to be how images look like, right? And if you talk about 2008 timeframe, 3D data looked like that, looked nice. We thought it was great, but it didn't represent how, if you open the patient up, during surgery, how do the organs look like? And taking advantage of the Xbox team and some of the Microsoft research folks that were working on photorealistic, scenes in movies and in games, like how do we take advantage of all this amazing 3D stuff that is happening and bring into healthcare? And how do we do it in a manner that is very high performing, does not require, gigantic, workstation to do this? How do you do it through the web? And that led to creating the GPU-based volume rendering. And we really had to start from scratch. So Toby Sharp on my team rewrote the CODA codec, the codec that is used to program GPUs. So NVIDIA had just come out with a Tesla card, and he, just to get the rendering to work really, really, really fast, rewrote the whole thing, what is called assembly language, basically is ones and zeros. And so this is now a prototype from 2009. 12 years ago, and just look at the frame rate on how, if I can play it. And this is, I'm showing this sitting in Washington, DC, if it plays, where data set is sitting in Cambridge, UK. So this thing is doing 30 frames per second, 3D, 60 frames per second across the ocean, across the Atlantic Ocean, in real time, right? So this is all running in a browser on my computer, whereas the data set and the cloud, the infrastructure GPU is sitting in UK. And that was the whole idea. How do you do photorealistic 3D? By learning how to reprogram a GPU, we decided, like, hey, how do we now expedite our machine learning? Can we take advantage of GPU to do that stuff? So this is what the conclusion was, the 3D ray casting based 3D photorealistic 3D that we did. We ended up actually this became part of Xbox's arsenal, and I think Siemens licensed a lot of the technology from Microsoft for their photorealistic 3D. What do they call? Cinematic 3D is what they call it. So it was all the work that was done at Microsoft to improve medical imaging around that. So we then applied the same techniques to expedite machine learning on GPU. So this is one of the early versions of automated recognizing atomic structures on CT scans at 200 frames per second. So basically, as the scan is getting done, you're automatically classifying which organs were just scanned. And so you could stop the scanning in real time if you've already covered the body part, or you can automatically generate reports based on what you're looking at. So there were a lot of interesting ideas on how to do this. Again, the vision of how do you create a GPS for the human body. And this led to a lot of different things. And again, the big thing was that this is not image segmentation. We were trying to do image recognition, to where things are. So in 2009, I got a call from another team in Microsoft that was trying to do the same thing, recognize something, but not in medicine, but in healthcare. And they said, well, we have this problem that we're trying to recognize where the head is, where the hand is. Can you help us figure out how to do this? And so the image on the right is actually the 26 body part segments that I did as a prototype from this grayscale stuff that they were showing me. And like at that time, I didn't know what the use case was. They just wanted us to figure out how to do this segmentation. So this was Jamie Shedden, Antonio Cremonesi on my team at that time, working with us, Toby Sharp. All of these were on the team at Microsoft working on this. And I'm sure you can guess what this is. This ended up becoming the foundation technology to recognize humans during gameplay. So you can see direct work that we were doing in CT scans in medicine, and how we use GPUs to do recognition ended up getting translated to Xbox. Before this, they were trying to do a CPU-based work to do this, and they were running into problems, and we ended up expediting a lot of the stuff. And even a lot of people in my team at Microsoft in healthcare didn't know that this was happening because of such a hush-hush stealth project, and some of us were getting sucked into to support this also. And one of the key thing was we needed a lot of data to train, so that we didn't want the thing to work out of the required training to play a game. And so we had to create synthetic data. So the images on the top are real humans that we've segmented, and the images in the bottom are all synthetic data. And you can see some of these patients, the people have like elephantitis type legs and weird shapes, right? So, but what we realized was that if you had enough data, it overcomes all the errors in recognition, right? So we ended up generating 500,000 1-hour videos at 24 frames per second. So 24 times 60 seconds times 60 minutes times 500,000, and trained the model on that massive data set. And we had to build the whole architecture of 100,000 GPUs just to train this model to recognize human body parts. And that infrastructure ended up becoming the foundation of Azure machine learning that exists now at Microsoft. So a lot of these early things we were doing, trying to solve these problems, ended up becoming a crucial part of various aspects of Microsoft's technology. And this is the actual work that was published around this on using synthetics to train. And then actually at Hyperfine, we're using the same techniques now to train on stroke applications for the models that we are building. So again, a lot of this work is translating, you learn from one aspect, go to the next one, innovate over there, learn from there, go to the next one. And that's kind of have been my journey. And what made the whole thing worth is this is one of the early prototypes I brought home for teams to my kids to, see what it is. And they're playing a game and all they're doing is popping bubbles. This game never got launched. But
We're the jumping boy. We're a jumping boy. Jumping.
This is 2009, right? So, I mean, when you do this, when you see this, then all the work you've done, that's your reward and nothing else, right? So that was the exciting part of it. Anyway, I'm going to stop there on my journey there, and open up for question, and then we can go back to talk about Hyperfine.
My God, that was just superb. That's fantastic. I mean, a lot to unpack here from a wisdom perspective. I mean, entrepreneurship is a journey. I mean, people say, you had the idea on a napkin. No, it's an evolving thing. You have to stick to it. You need grit for it. Your wife knows you better than you know yourself. And then data is the new oil, and you have to be good at data no matter what your field are, and especially in medicine. And as you can see, the applications could be multi-tangential, and it can be applied from one industry to another, and you can innovate your way in or out of different things. And then it's amazing to see the history of CPU to GPU and actually coding at an assembly level, because that's really, really hard if anyone has tried to do that. I mean, now we live in a different world, right? I can go into Google Cloud and then get a TPU for 10 cents a minute or something, which is very different in your time. So, I mean, fantastic. I mean, and those who have been following the history can really appreciate like how hard that work has been. And the last point that you bring is very, very important, that we do all this for able to make sure that we can share this with our loved ones. So thanks for doing that. I really appreciate it. There are not much questions. I think we can just go directly into the key innovation. I think you have. Sorry,
Junaid,
go
let
ahead.
me ask a couple of questions, if you would.
Sure.
And I think we are a small enough group that we can allow people to unmute and ask their question. We raise your hand if there are a few people who are asking questions, if you want to be queued in, and feel free to start your video and jump in. So Dr. Khan, one of the things that often when we see someone who has so well achieved, and it looks so hard to understand, okay, where did the process started? Because we're at the starting point at zero, and just copying someone who's already across so many finish lines is just so mind-boggling. In listening to you, it seems like that early exposure to programming, and then either getting opportunities or having interest and keep utilizing it in your med school, in your residencies, became that foundation which gradually got you to the point where you were doing such huge and tremendous projects. So any lessons from that, any suggestions on how to kindle that fire, how to get started, how to lay those foundations? And from was it your personal interest, was it the opportunities, did you have to go and ask for things, or you have to were you planning to design it that way, or it just happened fortuitously? Or any comments on that?
Yeah, I think you gave me a lot of credit, right? So once I started to build the habits of how to be a good leader, how to reflect, how to understand, right? I mean, I'll tell you, like in my Maryland days, I was egocentric, probably prick if you would ask some people, right? I mean, it would give people a hard time, was always on edge, things not happening, your classic, academic professor who's all the time at the edge and scolding people, and people are not, everybody's incompetent. That's kind of how I used to be. And I think what I've done, I think what has happened over time is really understood the value of leadership and how it's different from management, and the ability to reflect back and see what has contributed. I actively suppressed all of the things that I knew from a computer science point of view till I started doing informatics, right? So if you look at my early CVs or early residency applications, things like that, I would just not talk about this stuff because I thought IT, there's people who fix mouse and keyboards, right? That's kind of in my mental picture was, and did not think that was the respectable profession or things like that. It's a very naive way of thinking. And I think in hindsight, it's those early experiences what has made me or enabled me to do things that I've been able to do afterwards. And again, I'll give you an example. And we have a professor at Aachen, Dr. H.R. Ahmed. Some people from Aachen would know who he is. 2 weeks into my first year of med school, he wanted me to work on some hypertension study he was doing, just because he needed some data, somebody who could handle data. And suddenly here's I am somebody who can actually do this. And I hated that project, right? I had to go to obstetric clinics after my basic science work and classes I do in the evening, and go measure blood pressure real time on pregnant women in Pakistan, and do orthostatic hypertension, right? The stand up, lie down, and document that stuff. And I would be in the clinic, but clinic in Aachen used to run like till 7 p.m. or whatever it was. So here's 2 weeks in first year med school student. I have to do my basic science, anatomy, physiology, biochemistry, all the stuff. But after classes, I have to be in the clinic, do this cut work on measuring blood pressure for the first semester. And it was affecting my scores, right? I was failing in my basic science test. But now then look at it, when I started Higgy, I had such a deep understanding of hypertension and how it's measured and how the fluctuations happen, how somebody sits, somebody stands, that I would not be able to do what I did Innovate in Higgy if I had not done that project in 1990 because Dr. H.R. Ahmed made me do it, right? So something that I actively, despise doing. There's another one. One of the cardiologists in Aachen, Dr. Najib, wanted to do ACLS, real-time data collection, and cardiac arrest was happening. So I was carrying a pager 24/7, and any code that would happen in Aachen, I had to go show up and collect data, what drugs were given at what time, what happened, so you could be 2 a.m, could be in the middle of a class, middle of a lab, and you're running around as a single person doing all this stuff. It literally felt like internship in my 4th year of med school, and it was insane amount of pressure. And again, the survival rate of the study was 2%, and I myself documented 150 patients. So you can imagine seeing death after death after death. It created psychological, mental, emotional things too, but it really helped me understand how do you think about intensive care, how to think about patient in those critical scenarios, how to think about data access and need for emergent things. And it is so relevant to Hyperfine right now, right? Because I used to be in those ICUs every single day in those critical patients who we were doing things blindly because we didn't have imaging access, and just given the insight to it. So learning is that any experience that you do, even you hated whatever it was, you have no idea how it's going to actually go and impact the future. And I think the things that I did not like to do or actively suppress ended up becoming the main things that led me to do innovative things in the future. So, and that's I think one thing I've also learned is that always be in a learning mode. So, probably you've heard a lot of successful people read a lot. I mean, in the pandemic, I read 130 books. In 2020, right? So I think that's my record of in a year number of books I've read. And again, I read both fiction and nonfiction type of stuff too, and it just being a constantly learning mode. And again, I do a lot more on audio now than actual reading the books. But I think that's what has happened, building the attitude of, I don't know, I'll look it up. So not be afraid of trying new things, even if you don't know anything about it. Always be learning, and there's no individual and there's no idea that is wrong. I'll tell you, the Higgy was supposed to be a data platform, was not supposed to be a kiosk company. And we were struggling to figure out how we're going to collect this data from patients to understand risk in the population. So again, we can provide solution. It was an intern on the team that said, what about these kiosks? And my answer was, those are stupid, never work, always incorrect. And he goes, exactly, right? So why won't we go disrupt and build something that is better, right? And that's pivoted. It was not my idea at all. It was an intern, and I couldn't convince him to stay with me. I mean, he's doing big shot now. He's a big shot strategy person at Humana, running the whole Humana strategy, but he was an intern in my team at that time in 2012 who came up with the idea that we should be doing kiosk. And so again, the Toby Sharp that I talked about, the example, Toby was a developer, and this whole story on how he even got to GPU, we all resisted. We did not want him to do this. And we did a fun sprint in which he decided in that fun sprint, that's the thing he's going to work on. And it completely changed the whole history and enabled all the things that you saw. So again, sorry, Danish, such a long answer to your question, but it's not that simple answer.
No, that's wonderful. I have one more question, but I see that Professor Sarwat had raised his hand. I'll let him introduce himself and ask his question, and I'll cue myself a second after him. Professor Sarwat, please go ahead.
Ji, Assalamu alaikum. Dr. Khan, how are you?
I'm good, how are you?
Just a matter of history. I used to know Dr. Bob Grenis at Harvard Medical School when I was there in 1983, and we all used to think that, we don't know what he is doing, and we never understood what he's up to. He was boring, and really nobody really listened to him. No, my question actually is that, first of all, your presentation and your career has been exceptionally inspiring. And obviously, all of us want our children and grandchildren to follow your course. And looking back, you could say what choices you made, but obviously, if we look prospectively, there must have been several roads to take from every juncture that you took. And there obviously tremendous amount of uncertainty at the time, when you embarked onto something. Now, the question is that what are some of the things that might lead to your kind of career starting from now looking forwards in terms of technology, since that's your field, and how to embark on that and how to choose them?
Wow. Dr. Sarwat, you always have very deep questions. Like sometimes I wish I have all these answers, right? For me, a lot of things have happened because there's the time, the place, and I am, and the opportunities come up, and I've jumped on it, and sometimes I've not jumped on it, and regretted later on not to do the stuff. I really wanted to do cardiac MR as my clinical specialty. I had really big ideas and ambitions of what I wanted to do. And I even got into fellowship at UCSF with Charlie Higgins to do my cardiac MR fellowship over there. But then life hits, right? We found out that my wife's pregnant and we're going to have our first child, and she was going to be in her 4th year radiology residency at Geisinger in Danville, Pennsylvania, where I'll be sitting in San Francisco in the warm, sunny California, enjoying my fellowship. That just would not have worked. So I called Charlie, asking him, like, what options do I have? And he said, listen, we would love to get you next year. So why don't you come and we'll figure out how to get Pfizer fellowship too. So, but suddenly now I'm in my 4th year radiology residency. Every fellowship is already taken. I have to look for a new fellowship. That became the driver. Like, I had to find something now. Nothing existed in the 3-hour radius that I could drive to, and while support her during her first pregnancy. And then it was my program director secretary who said, like, all this informatics things you're doing, isn't there a training program there you can look for? And he's like, there's nothing. He's like, maybe they just don't advertise. And that led me to start calling every single department, asking. I literally would have department chair, I'd do the list of all the state of computer application radiology's board members, American Association of Medical Informatics board members, committee members. I had found all their phone numbers, would call and ask anybody who has informatics fellowship. And it's like, what is that? Was the normal question. Like, is there such thing as informatics training program? Like, not in imaging. So there were PhD programs in informatics that Bob Greenius had and a few other people had, but nobody had a fellowship. And I didn't want to go do a 4-year PhD somewhere else. And again, my radius was from Geisinger. So it was max I would go to is Pittsburgh. It was Baltimore. It was Philadelphia, Hershey. That was the radius I had to look for something in and convince. So, and then I had to convince people to start a fellowship program. I mean, can you imagine a Pakistani kid in Geisinger calling chairmen of radiology, trying to convince them to start informatics fellowship? I mean, there's a whole story on YouTube on Elliot Siegel and me talking about how that happened. Random call, somebody call and say, like, hey, you need to start informatics fellowship and I'll come and run it. So, I mean, he took a chance, right? The dean at University of Maryland, and he took a chance on that. But I'm sure I did something right to convince them to do this. And you just have to be hungry what you want, right? And just go after it. And that's, I mean, I give my wife's example, right? When I was doing my internship at NYU, she had just finished her med school and she had a year before her internship would start, and she wanted to find research positions. And she basically found every single assistant professor, associate professor in the island of Manhattan, and would physically show up with her CV, knock on doors and say, I want to do a research with you. Ended up doing it with Vivian Lee, who ended up becoming chief science officer at NYU, then dean of University of Utah, and now he's head of Verily, the Google's healthcare program. So when Vivian meets, she never introduces me as Siddiqui radiologist. She says, oh, he's my former mentee's husband. She's the only person who introduces me like that. And any of the big, I mean, obviously, she's now in the same circle that I am in informatics, technology, entrepreneurship. But that's my wife's connection, right? In which she did her MR 1 year of research with Vivian Lee, who had just finished her fellowship at NYU, had just become a faculty and was looking for somebody to help her with her research. So again, you have to be tenacious. You have to go after what you want. and just, you will get 100 no's, and then the 100, if you haven't tried 100 times, I remember Pfizer did 110 physical visits with all the faculty on the island of Manhattan to try to get a fellowship program. And I probably made similar amount of calls. And I mean, even now when I raise money, when we raised 90 million at Hyperfine, right? I mean, I'm probably talked to over 100 VCs before we were able to raise 90 million to do that stuff, right? So it's never easy. No matter how many times you've done this, it's always hard, and you just have to have that passion behind it, and just don't take no for an answer, and just figure out how to do it and learn from it. If it's not working, then you have to learn, fail fast, right? Can't keep doing the same thing again and again and again, expect something to change. I hope, Sarah, that gave kind of a long-winded answer. It's all about tenacity. It's all about going after what you want, and it's all about, learning from your mistakes and changing fast.
That's so wonderful. That's amazing. And thanks for sharing all of this. It's really inspiring and very, very useful information that is often not discussed or taught, when we are being even mentored. One question that I wanted to bring up to you, Dr. Khan, was there seems to be just this aversion to industrial side in the clinical side, especially academics. If you're working, the academics don't want you to interact, don't want you to, you will somehow catch a virus and get corrupted, and you will be useless for the academic sides, and they don't want you to have coffee with anyone or lunch or go attend a meeting or talk anything. So there develops this kind of a resistance, and there's a thought, oh, often we still joke, oh, he has gone to the black side. So if someone took a job at an entrepreneur, at a company, they say, oh, he has gone to the dark side, he's gone to the black side. Well, how do you see that? How do you make your transition? What can we do to reduce those barriers or change that culture, especially on the academic side of medicine?
Danish, I was the same way. It took Microsoft 6 months to convince me to move, right? So I would have the same exact attitude. And funny thing is, like, I did more academic publications at Microsoft than I did before Microsoft. Like, I think in 2010 or 11, I did 22 peer review publications at Microsoft, right? So, and we were doing so much in machine learning and so much in medical imaging stuff, right? There was just so much happening. I mean, even at Hyperfine, I don't even remember how many, like we had 12 abstracts at ISMRM from our team, right? So it doesn't mean that you're going to end, your academics or passions that you are going. Just be clear why you are joining somebody and why you're doing something, right? And what is your goal? What is your vision? And how you are constantly learning and improving things and keeping your academic mindset. I mean, we are still academic mindset even in Hyperfine. I mean, there's so many PhDs in the team, and they're all academic. They're all postdocs. They've all done their thesis. They've all published. They've all been. I mean, we have the editors from Radiology Journal is on the team as a clinical scientist. We have people who are moderating sessions at conferences. Teaching people as part of our engineering team, right? So, to me, it's a part of the same continuum, right? So I think that it's always like, everybody you talk to non-physicians, they think every doctor is the same, right? I mean, how many times like, oh, yeah, something going on in here, you're a doctor, you know how to do this stuff. It's like, no, right? So it's the same thing on the computer science side of things, engineering side of things. We think they're all the same. You just need a coder to do software, and they're way more specialized than anything else, right? Somebody who can do websites and build amazing applications would have no idea how to build an app for iPhone. I would actually build a pretty bad thing because it doesn't translate. At least in medicine, we learn all these things, and have basic understanding. In engineering, they specialize so early, so fast that it's almost like, medicine and dentistry, right? You don't know anything about the other specialty. So I think it's just why you're doing it, and why you want to do something, and how you're going to make the difference. And my eyes opened up, right? I also had the same perception that, oh, this industry is going to be all, just business people and things like that. And it is very different. It's very fast moving. You react fast, you innovate fast, you move fast. I mean, Hyperfine, when in December 31st, we were 47 employees. this Monday we'll be 108. Right. So, the team's growing really, really fast. So.
Wonderful. Professor Sarwat, do you have a comment?
In fact, I have a question. My question to Dr. Khan is how can you help IT and artificial intelligence in Pakistan?
Oh, absolutely. That's a great aspect, thought process there. I think all this starts, to be honest with you, everything starts with the.
Yeah, sorry, can I interrupt you? Let me just ask you a question. If we, the Apna Merit group or Apna people, get together, let's 10 of us get together and raise $1 million to start a startup IT company in Pakistan, what are the prospects and how can you help them?
Okay, so I will do completely opposite. I would start with the problem first. I would find what is the problem you're going to solve first, and then figure out how to solve it, right? And AI may not be the right answer for it, right? So I've always done that. I've always.
I have a lot of problems in mind.
Yeah, so I think the right thing to do is get the team, identify what problem you're going to solve. Is it going to create a big impact or not? Is it, if you do solve it, will it actually be the issue with building a business is that it has to be viable financially, right? It has to have a business model. It has to have the right product market fit. So I think the early work is really supposed to be, make sure you understand the problem, make sure it's a big problem, make sure people care about the problem, and then don't get married to an idea, and then iterate to figure out how to solve it the right way in the right context for the right audience, right? And sometimes it will be a mobile app, sometimes it will be, nothing to do with technology, right? It'll be, maybe it requires humans to do it. But I think that's how I approach a lot of these issues. I always recommend think about the problem first, think about what it is, and then build the right team that go and figures out how to solve it. And they should have all the tools available to them on how to solve it. If it requires machine learning, AI, data, absolutely, then they can go solve that stuff. But don't start with what in it. Otherwise it becomes like, you've identified a hammer and now you're looking for nails. Where can I use the hammer? It just becomes more of a idea looking for a problem solution then.
Awesome. Thank you so much, Dr. Sarwat, Dr. Bhatti, for all those questions. Just to summarize, entrepreneurship is a mindset. Be humble, open to opportunities, work hard, make sure that whenever these things come by, you pay attention enough. Look for the pain point, as you suggested in your last point, and the solution that is marketable, profitable, and financially viable. So thank you again very much. I really appreciate all that. I'm very grateful for this advice, especially for young physicians. Glad you made it to the end. If you save a life, it is as if you saved the life of all mankind. This is my guiding principle. Please do your part, like, comment, share, and make sure you subscribe to my newsletter and my YouTube channel for future updates. If you want to connect with me, Twitter and LinkedIn is the best place. Feel free to send me a message. Thank you so much.